understand that hypertension developing 20 weeks after 20 weeks of gestation with one or more of the following: either proteinuria, maternal organ dysfunction, including renal, hepatic, hematological, or neurological complications, or fetal growth restriction. It is important to note that this definition does not require proteinuria to meet the diagnostic criteria of preeclampsia anymore. On the other hand, the inclusion of fetal growth restriction in this definition may increase the number of women meeting the diagnostic criteria for preeclampsia.
Has to be absolutely perfect, and this should be measured with the woman in the sitting position, with the arm at the level of the heart, legs uncrossed, and after a 5 minutes rest. No coffee, tobacco half an hour prior to the measurement of the patient. And it's always a good practice to ensure that you are using the correct cuff size, which has to be appropriate, where the breadth of the cuff should be 1.5 times the circumference of the arm of the woman. And you have to be also carefully recording the correct cuff sounds. Now, correct cuff 1, as we all know, is for systolic blood pressure.
Now, what about genetics? Preeclampsia risk is influenced by the mother's genetic background and genetics of the fetus. Genome-wide association studies by screening more than 7 million genomes and looking at more than 2,000 neonates born to preeclamptic mothers, they found this FLT1 locus in chromosome number 13. So the pathophysiology, the main is in the dysregulation of this FLT1 locus in the fetal genome, and this dysregulation is responsible for the placental dysfunction.
The mainstay, but the concept of preconceptional care and counseling has not adequately developed in India. There is a need of mass education to be involved couples for preconceptional care and counseling before she becomes pregnant. Till then, as an alternative, what we can do? This can be done to some extent to tackle the situation in two ways. For primigramida woman, counseling and risk assessment should be done in first antenatal visit, and postpartum period should be used for postpartum assessment and counseling for future pregnancies.
Friends, your entire team should be very familiar with the anticonvulsants. Magnesium sulfate is the gold standard for prevention and treatment of eclampsia and for the prevention of preeclampsia to eclampsia. So be very clear about the dosages. There are two preparations available, 50% weight by volume and 25% weight by volume. We prefer the 50% because it's easier to calculate. A 2 ml ampule is equivalent to 1 gram. So 1 ampule is equivalent to 1 gram. Therefore, the loading dose, if you're going to be using the IV, 4 ampules of 50% weight by volume is equivalent to 8 ml, and that is 4 grams. This is diluted with 12 ml normal saline, given slowly over a period of 15 to 20 minutes, not less than 1 gram per minute.
It's a placental disease. So there have been lots of data that preeclampsia is essentially resulting from placental ischemia. So you can have placental ischemia from genetic factors, from maternal environmental factors, such as, patients who have predisposing risk factors, such as diabetes, hyperglycemia. There can be immunological factors, but whatever these factors are, they lead to abnormal placentation. What happens is there is in normal pregnancy, there is from proliferative cytotrophoblast to invasive cytotrophoblast, which go deep into the uterine endometrium and myometrium. However, in preeclampsia, there is superficial invasion and there is narrow maternal vessels, so which ultimately leads to placental ischemia. There is data that there is evidence of oxidative stress as well as persistent hypoxia in women who have preeclampsia. So there is evidence there's increase in HIF1 and HIF2 alpha in the placenta, and also autoantibodies. Now, these can lead to IUGR, but what we're talking about is that this diseased placenta then causes release of circulating factors, which we'll be talking about, mostly soluble FIT1, soluble endoglin. Also, there's release of syncytial debris and pro-inflammatory cytokines into the maternal circulation.
Preeclampsia. Systolic blood pressure, baseline antihypertensive therapy, magnesium sulfate treatment, gestational age and platelet count highlighted in purple because these overlap with the full Piers model, serum urea, urine protein to creatinine ratio. And then there were also some components that are not in the PrEP-L model that we'll talk about in the next slide, but are just specific to this one. Serum creatinine that also overlaps with full Piers, ALT, so alanine aminotransferase, so liver enzyme, and exaggerated deep tendon reflexes. So a lot of variables that have gone into the PrEP-L model. You can see that the area under the receiver operating curve is 0.75, so a potentially useful test. And now if we turn our attention to calibration, what we're looking for is to see how closely the solid line, which is the observed risk, relates to the predicted risk, which is in the dotted line.
Out of this, you can actually look at three circles here. All right. So 103 people had the negative biomarker ratio. That means they had something like less than the 33. And say about 22 encounters had something like less than 85. And the ones who were between 33 and 85 were in between. All right. So we found that the ones who had a negative predictive ratio did not develop severe preeclampsia in a week. So it was something like 100% negative predictive value. And the positive predictive value of somebody who had more than 85 was as high as 60%. And this closely correlated with the prognosis study, which was published also recently. But probably they used a cutoff of 38. And in fact, we also tried to find out what happened if we changed the values from 33 to 38, and we did not really have to reclassify this patients again. So this closely matched with that prognosis study.
We have completed another validation study unique to India using this handheld point-of-care device among women presenting with new onset hypertension at greater than 20 weeks gestation, with or without proteinuria. Control patients were the next patients seen in the same facility that were normotensive without proteinuria, enrolled over the similar time frame. This was carried out in 3 centers in Hyderabad, and assays performed the glyphosate by the point of care, and then PLGF, SFLT, PAP-A2 by commercial immunoassay. Preeclampsia at enrollment was defined as hypertension with proteinuria. Gestational hypertension was defined as hypertension without proteinuria, in accordance with the International Society for the Study of Hypertension in Pregnancy.
Hello, everybody. In this module, we start with the panel, which is going to discuss the various clinical challenges, the management protocols, the investigations, when to deliver, how to deliver, and so on. We have already gone through the various modules, wherein we have been told as to what has to be done for each of the particular situation. Now, today we are going to come down to the ground level and see what we do when a real patient comes to us. And to discuss in this panel with me, I have stalwarts from all over India. The first panelist, Dr. Preeti Kumar, who is the chairperson of the Safe Motherhood Committee of FOXI and also the vice president of the Lucknow OBGYN Society. Welcome, Dr. Preeti, and I'm sure our delegates will learn a lot from you.
Thank you so much, sir.
The next one is a very serious and a very senior person, Professor Saswati Sanyal Chaudhary. She is the professor, Department of OBGYN in Guwahati Medical College, and she was the chairperson of the Medical Education Committee in the year 2013-2015, and she's the past president of the Guwahati Obstetrics and Gynec Society. She has a vast experience, and she herself has done a lot of research in the field of preeclampsia in her medical college. And I'm sure, madam, whatever you tell us and our delegates will be definitely worth their while. Welcome to the panel. Next, we have a panelist from the South, Dr. Charmila Ayavu. She's the chairperson of the Clinical Research Committee of the FOXI in 2016-2018. She's the national coordinator for the UNICEF FOXI PSA. She's into a lot of community service, community education, and that kind of a situation. She's the past secretary of the Trichy OBGYN Society, and she's the joint secretary of the Gestosis India Association. Welcome, Dr. Charmila, to the panel.
Thank you so much, sir. Thank you.
The next question goes to Dr. Charmila. How is this? See, there are two conditions: preeclampsia without severe features, and then there is gestational hypertension. How are these two diseases different?
The development of proteinuria will differentiate between gestational hypertension and non-severe preeclampsia. So you need to do a urine protein a dipstick analysis in every visit which he comes as a gestational hypertensive patient. And the methods you can do is either by a urine dipstick, which can be automated, or a visual dipstick method. And if necessary, if you have the facility, you can do a spot urine protein creatinine ratio, which is supposed to be much better than the urine dipstick analysis. And when it crosses 2+, then you take it as preeclampsia. And that's where you differentiate between gestational hypertension, where she's developed hypertension after 20 weeks, but she's developed proteinuria now. And now she becomes non-severe. She does not have any complications. The labs are normal. The baby is normal, and she does not have any symptoms. She's in the non-severe category.
Thank you, Dr. Charmila. But we know that 50% of the women with gestational hypertension will eventually develop proteinuria. Welcome to this module 4B of the PENI program. In the first 3 modules, we went through the various aspects of preeclampsia in detail. The 4th module is a module about clinical challenges and on-the-ground facing of these preeclamptic patients. The 4th A module, which you have just completed, had the various aspects covered, including the management, the measurement of the blood pressure, the classification of preeclampsia, the management of gestational hypertension, the management of a patient who has had a previous preeclampsia, and that included prevention and prediction. And finally, we had the management of a non-severe preeclampsia. In the module 4B of PENI program, we'll be discussing the clinical features and the clinical problems that we face in severe preeclampsia and how to address this. So basically, this module is what we call the enfant terrible of preeclampsia. That is the infant terrible of preeclampsia, where we are going to come across all the complicated cases. How do you identify them? How do you manage them? And to do that, I have with me on the panel very eminent personalities. We have Dr. Jyotsna Suri, who is the head of the critical care obstetrics at Safdarjung Hospital, New Delhi. We have Dr. Pratna Shah Deshpande, who is a specialist in high-risk obstetrics and fetal medicine, and she's the first MFM consultant in the Marathwada region. And then finally, we have Dr. Mrityunjayana Bellad, who is the chief consultant at Kaylee's Dr. Prabhakar Kore Hospital and Medical Research, Belgavi. All these panelists involved in today's program have got a great lot of experience in the management of preeclampsia, and many of them have contributed to the maiden research in preeclampsia.
As soon as we stabilize the patient, we have to do the delivery. We cannot wait for steroid effect here. Some cases of HELP syndrome, which come in a stable situation, who have not had fit and who are absolutely stable in other ways, who are not bleeding, who don't have abruptio, those patients who are in the preterm between up to 34 weeks, we can sometimes take 48 hours for giving the corticosteroid for the lung maturity.
Disabilities, in particular cerebral palsy. In the long term, there's a higher risk of impaired work capacity as well. In 2019, our screening and prevention approach was endorsed by FIGO, recommending that published algorithms should be used for converting the measured values of mean arterial pressure, placental growth factor, uterine artery Doppler, ± PAPE into MOMS. Patient-specific risk for preterm preeclampsia is calculated using the based method.
A paper looking at the levels of angiogenic factors with myocardial dysfunction. And essentially what we did was we had 3 groups of patients, women who had preeclampsia, group A, normotensive women, group B, and then patients who had chronic or gestational hypertension, group C. We measured their soluble fit PLGF before delivery, and as expected, patients who had preeclampsia had much higher soluble fit compared to patients who were normotensive, and they also had much higher endoglin levels. But more importantly, when we did their echo, what we found that patients who were preeclamptic, they were not in frank heart failure. Their EF was preserved, 57% in preeclamptic versus 58% in normal. What was going on that their GLS, which is global longitudinal strain, which is a metric of diastolic dysfunction, and actually abnormal GLS is associated with long-term cardiovascular disease in non-pregnant patients. What we found for one of the first times was that this GLS was very abnormal. So it was abnormally low in women who were preeclamptic at the time of diagnosis compared to normotensive.